Welcome to this lecture on PET-CT imaging for prostate cancer. These are the objectives for this lecture. The prostate is a small walnut-shaped gland in males that produces the seminal fluid that nourishes and transports sperm. The most common cancer and the second leading cause of cancer death among men in the United States is prostate cancer. In 2023, for example, there are estimated to be 288,300 new cases of prostate cancer. In 2023, there are estimated to be about 34,700 deaths. There are several subtypes of prostatic adenocarcinoma. Some of them are listed here. All of them will have varying degrees of aggressiveness, hetero or homogeneity within them, and different prognosis. It's very important when a patient gets diagnosed with prostate cancer that the subtype be identified through biopsy. This diagram is showing the overall progression of prostate cancer and how it metastasizes. So I want to point out here, this is the prostate gland, and the lymph nodes, there's a large number of lymph nodes that will surround this area of the body and be kind of embedded in the groin. There's also an avid blood supply to it, and there are nearby organs such as the urethra and the bladder. When cancer metastasizes, it metastasizes through the lymph nodes, through the blood supply, or by seeding to nearby organs. Prostate cancer has all three of those possibilities, and so it is one of the cancers that will readily metastasize, and because of the avid blood supply, it will metastasize even to distant organs. So with stage 2, cancer will spread to both prostate lobes. Once it gets to stage 3, it starts to seed to nearby organs, including the seminal vesicles. And then stage 4, it is present in the lymph nodes, and it has also seeded to nearby organs such as the bladder. There are several diagnostic tests that are useful in diagnosing or staging prostate cancer. The first test is the digital prostate exam. This is very good for preventative care to catch prostate cancer early, and it is also the first step often in diagnosing prostate cancer. Blood tests will be used throughout a patient's progression with the disease, and one of the primary blood tests is prostate-specific antigen. And then biopsy is also important. This is usually ultrasound guided, and of course is one of the first steps in the initial diagnosis and staging of the disease. Ultrasound can be periodically used with the initial diagnosis. Of course, the biopsy is ultrasound guided, but then also as the disease progresses locally. Ultrasound is often not the best choice when you're looking for metastases, especially to see if it has metastasized to distant organs such as the bones. CT is often used, and MRI, and they're very good measures of looking at structural changes and metastases to the whole body. Nuclear medicine, though, is a very good diagnostic tool for prostate cancer patients. Often at the initial diagnosis, to get proper staging, patients will get bone scans and FDG studies. After it's been removed or the prostate gland has been treated, if the PSA begins to rise, fluciclovine, or also known as Axumin PET scans, are very useful. PSMA agents are good at looking at the to see if it is a PSMA if the resecting tumor, and to be evaluated for PSMA treatments. And then choline and acetate with carbon 11 are also sometimes used, although due to the half-life of carbon 11, that's kind of restricted to more academic and large hospital institutions that have a cyclotron on site. And this is one example of, this is put out by Lantheus, but this is showing the spectrum of imaging modalities that are used depending on the stage of the disease. And so if you'll notice that it goes from structural to more functional towards the end. So in the very beginning stages of diagnosis and staging, ultrasound, especially transrectal ultrasound, is useful. And that's, when you're getting the initial diagnosis, like I said. CT scans are used often in the early stages, and this provides a very good detailed view of the anatomic structures. So it can be good for initial staging and even looking at restaging or progression of the disease if you're trying to identify tumor. The multiparametric MRI is used for looking at metastases. It's really good at getting that fine detail in the soft tissue that's in that area of the body, and it also does not produce additional radiation exposure. PET-CT scan, though, once the person gets diagnosed with prostate cancer, they're restaging the disease or looking at new progression, new metastases, evaluating the efficacy of current treatment, seeing if the chemo or radiation has worked or if the cancer has returned, if patients are getting rising PSA levels in their blood. PET scan and bone scans are really useful for evaluating the extent of bone metastases or any kind of metastases with the patient. Prostate cancer that's more advanced may cause signs and symptoms such as trouble urinating, decreased force in the stream of the urine, blood in the urine, blood in semen, bone pain, losing weight without trying, and erectile dysfunction. The metabolism, micropathology, and microenvironment of prostate cancer is extremely complex, especially as it can morph into different types, or as it progresses, the cells become more and more undifferentiated, or more and more like a cancer cell and less like a prostate cancer cell. So with that, amino acids play a very valuable role. The L-type amino acid transporters, or that's what the LAT stands for on this slide. The L-type amino acid transporters promote prostate cancer progression in several ways. First of all, they increase the uptake of essential amino acids into the cancer cells. These essential amino acids will support the growth and the survival of cancer cells. And then after being delivered into the cells, the amino acids are used to make proteins, nucleic acids, lipids, and ATP for energy, so that the cells can have more energy, they can divide and metastasize and undergo that mitosis a little more avidly. Cells will have PSMA receptors on the surface of them. PSMA stands for prostate-specific membrane antigen. These receptors are overexpressed on prostate cancer cells with the androgen pathway. And as cells will progress and become more and more cancerous, they may start to lose the receptors, but they play a very important role in the growth and development of prostate cancer cells. And they're basically a glutamate carboxypeptidase and folate hydroxylase. PSMA is very complicated because this is kind of a misname. It's related to folate metabolism and folic acid presence. So really, it helps the cancer to grow. It has a signaling role in prostate cancer cells that activates the growth pathways. So when these receptors are overexpressed on the surface of prostate cancer cells, it kind of indicates that the cancer is actively growing and metabolizing, or I'm sorry, metastasizing, and using that androgenic pathway. As the tumor progresses into stage 4, becomes more and more metastatic, um, then sometimes they will lose the receptors and they're no longer prostate cancer cells at that point. They are just cancer cells. Another one is glycolysis, and mutations in the P13K pathway. The P13K pathway is a kinase pathway that is associated with proliferation of cells in cancer and things like that. So they make tumor cells hyperactive in response to insulin, and they signal cells that insulin is present. The cells in turn open a valve that lets in sugar. So this is where the cells take up sugar, and it will be seen on FDG studies, but as it is very closely associated with cell proliferation. And then there's also a neuroendocrine component to it. The neuroendocrine component, mostly known as neuroendocrine prostate cancer, or NCPC for short, it's an aggressive histologic subtype of prostate cancer that most commonly arises in the later stages, and it's really resistant to treatment. So neuroendocrine prostate cancer is an aggressive variant of prostate cancer that may arise de novo or in patients previously treated with hormonal therapies for prostate adenocarcinoma. And it's basically a mechanism of resistance where the cells will differentiate and become neuroendocrine cells. And the additional heterogeneity and progression that makes it very hard to detect in imaging. So these patients would no longer show up on PSMA scans because they've received the hormonal therapies and the cells maybe are no longer expressing PSMA on the surface of the cells, but now they have that endocrine function. So small cell prostate cancer may also develop in later stages of prostate cancer progression. And this occurs in about 15 to 20% of the patients that are treated with hormonal therapies for prostate adenocarcinoma. And it's really a mechanism of these cells, these cancerous cells, are designed to survive, and they manipulate the environment around them and the microenvironment around them. And so they are actually changing in response to the treatment to become cancer cells that are resistant to whatever treatment they're getting. So when they are getting hormone therapy, and the PSMA receptors on the surface of the cells are oversaturated and it's blocking their development and their progression, then they switch and become neuroendocrine cells, and they're very resistant to therapy once that occurs. It's also a challenge for imaging because they may not be taking up FDG or PSMA, but they are still extremely aggressive cancer cells. Neuroendocrine prostate cancer does behave similar to small cell lung cancer, and sometimes it can be treated the same, but at this time there is no known effective treatment for it. So the prognosis for these people is pretty poor. So that brings us now to PSA, prostate-specific antigen, and this is a blood test that a lot of prostate cancer patients will receive, and it's a way of monitoring them for tumor progression or for metastases. So the PSA blood test is checking the level of prostate-specific antigen in the blood. And this is important to note that this is a non-imaging diagnostic measure of the PSA in the blood. PSA and PSMA are two completely different things, and one doesn't necessarily negate that the other will be present. So PSA levels as elevated or non-elevated rather than normal or abnormal, because the normal range will vary with age. So this is just a quick reference. Individual labs may change, and it may change slightly with age and other factors, but a 4 to 10 is minimally elevated, 11 to 20 is moderately, and above 21 is considered a high elevation. 4 to 10 nanograms per milliliter is borderline, and it represents a 25% chance of prostate cancer recurrence. 10 or higher is considered dangerous, meaning there's about a 50% chance of prostate cancer. And so I want to point out that even if it's high, that doesn't necessarily mean for certain that the prostate cancer has returned or metastasized or is progressing. PSA levels can be elevated for a number of reasons. First, prostate size, infection, prostatitis, recent urologic or pelvic procedure, an enlarged prostate or benign prostate hyperplasia, a urinary tract infection or irritation, or just being born with a larger than normal prostate. PSMA, on the other hand, is associated with imaging, where we're actually looking at the surface of the cells. So prostate-specific membrane antigen is a cell surface transmembrane glycoprotein. It's also known as folate hydrolase 1 and glutamate carboxypeptidase 2, and this is associated with neovascular-associated endothelium of highly vascularized tumors. The PSMA is overexpressed on prostate cancer cells in greater than 80% of men with prostate cancer. And this is diagnostic visualization of the PSMA receptors on sites of metastatic disease. The Gleason score is a rating system that's assigned to the results of a biopsy. Typically, there are 12 samples that are taken under ultrasound guidance to allow for distributed samples. And then the samples are examined under a microscope and assigned to a score based on the level of malignancy. The most common grades are added together to form the Gleason score. The Gleason score is important for patients with prostate cancer. A prostate cancer Gleason score or grade helps to determine how aggressively the prostate cancer is likely to behave, and the score will help classify the cancer by grading how quickly it's likely to grow. So on one hand, it's a measure of how aggressive and how metastatic that cancer may become. The score also indicates how likely it is to spread outside of the prostate cancer. So the prostate cancer Gleason score will range from 2 to 10. To determine the Gleason score, the pathologist uses a microscope to look at the patterns of the cells in the prostate tissue. The most common cell pattern is given a grade of 1. This will be most like normal cells, and then up to 5, which are the most abnormally looking cells. If there's a second most common cell pattern, the pathologist gives it a grade of 1 to 5. And the pathologist then adds the most common grades together to make the Gleason score. If only one pattern is seen, the pathologist counts it twice, so 5 plus 5 equals 10. A high Gleason score, such as 10, means it's a high-grade prostate tumor. High-grade tumors are more likely than low-grade tumors to grow quickly and spread. So this is an example of, or this diagram shows the Gleason score. Gleason score of 1, the cancerous tissue looks very much like normal prostate cells. So this would be in the early stages, all the way up to 5, in which the cells appear very abnormal. They don't look like normal prostate cells. A lot of times they don't resemble prostate cells at all anymore. They, at that point, look more like cancerous cells. So the pathologist will add the two most common grades together to find the Gleason score. Notice it goes from well differentiated as a 1 all the way up to poorly differentiated or anaplastic at 5. And like I said, at that point, anaplastic basically means that they no longer resemble the cell that they originated from, and they just look like cancer cells at that point. So the overall management of prostate cancer, first the patient will get surgical removal, followed by chemotherapy and radiation therapy. There are a few different types of radiation therapy that are beneficial to prostate cancer patients, but it depends on their stage and where their metastases is, if there's metastases and things like that. Oftentimes, patients will get androgen deprivation therapy, and this is the hormonal therapy that will block the PSMA receptors on the surface of the cell and block the hormone uptake so that the cells cannot metastasize or become as aggressive as they would otherwise. The PSA levels are checked in the blood fairly regularly. Imaging at the point that it is prostate cancer is MRI, CT, especially early on, or local metastases, bone scans to look at the if there's metastases to the bone, FDG, Axumin, and PSMA. And then FDG, Axumin, and PSMA all play a very valuable role together, as do bone scans. So it's not that Axumin or PSMA would replace FDG studying, it's that it is used as an adjunctive to get the entire picture of the patient. And so those are often used together, not in replace of. And then Pluvicto therapy for patients who have an overexpression of PSMA can be a very effective treatment. So now we get to PET-CT imaging for prostate cancer. The first one I want to talk about is F18 fluciclovine. The trade name for that is Axumin. And this is used to identify and localize suspected prostate cancer recurrence in patients with elevated PSA. This was FDA approved for the first time or was FDA approved in 2016. The method of localization for this one is receptor binding. The typical adult dose is 10 millicuries, and there is no pediatric dose just because pediatric patients don't typically have prostate cancer, so that was never evaluated as part of the FDA approval. So a little bit more about fluciclovine. The F18 component is cyclotron produced. F18 decays by positron emission 98% of the time. And then it also has electron capture that gives off a gamma about 3% of the time. It decays to stable oxygen 18 with a physical half-life of 109.7 minutes. The positron can undergo annihilation with an electron to produce 2 gamma rays. The energy of each gamma ray is about 511 keV. The mechanism of uptake for fluciclovine is it is a synthetic amino acid, so it's transported across the cell membrane by the amino acid transporters. This would be the L-type amino transporter 1 that we had talked about a couple slides ago, and this is upregulated in prostate cancer cells. Fluciclovine is taken up to a greater extent in prostate cancer cells because of that overexpression of the amino acid transporter receptors and that increased uptake of amino acids, or the supply that those cancer cells need in order to grow and metastases. And so that's why the method of localization is receptor binding for that one. It is indicated in patients, in men with suspected prostate cancer recurrence based on elevated prostate-specific antigen levels following a prior treatment. So these are patients who were initially diagnosed with prostate cancer. The prostate cancer was removed through surgery. Patients may have got their, preventative chemo and radiation therapy. And then in the monitoring period where they believe the prostate cancer was effectively treated, patients will get monitored for PSA levels in their blood. And these are the patients who they've been monitored for a while, the PSA levels have been good, and then all of a sudden their PSA levels are checked and now they are elevated. That raises suspicion for recurrence of prostate cancer or metastases of the prostate cancer. And so this is these initial patients where they believe that the prostate cancer may have returned. These are the patients that are most likely to benefit from the F18 fluciclovine. So the dose is administered IV as a 10 millicurie dose, and it should be administered as a bolus. It is important for the technologist to advise the patient to avoid any significant exercise for at least 1 day before imaging. And they should also be NPO for at least 4 hours. Small amounts of water are okay, but no other food or medication for, at least 4 hours. Advise patients to void approximately 30 to 60 minutes before administration, and then refrain from voiding until after the scan has been completed. Scanning will take place with the patient supine with their arms above their head, and the PET scan begins 3 to 5 minutes after the injection. So this is one where there isn't a lot of uptake period. The scanning will begin 3 to 5 minutes after the bolus injection, so it's fairly quickly. And it is recommended that the image acquisition should start at the mid-thigh and then proceed up to the base of the skull. And the reason they do that is because of the bladder activity. The critical organ for fluciclovine is the pancreas. That's the one that will get the highest radiation dose. And because it is amino acid, it goes on the amino acid transporters, and it's a synthetic amino acid. The normal biodistribution is a little bit different, so it's a little bit kind of varied. Normal biodistribution will include the liver, the pancreas, the lung, the red bone marrow, the myocardium, and the skeletal muscle. That skeletal muscle uptake is the main reason why we do not want patients to have any significant exercise the day before their scan. Localization of prostate cancer recurrence in sites typical for prostate cancer. Um, the patient prep for fluciclovine is that the patient should be NPO for at least 4 hours. They can drink a little bit of water, not much. Exercise, they should avoid for about 24 hours prior to injection. And the image acquisition, the wait time is only about 3 to 5 minutes post-injection. It does have a fairly quick uptake. The field of view, like I said earlier, starts at the mid-thigh and progresses to the base of the skull. The patient will lay supine with their arms above their head, and the acquisition is about 4 to 5 minutes per bed position. I do want to say with that acquisition, it will change based on the scanner and the age of the scanner, especially if some of these newer all digital PET CT scanners, the acquisition time is a lot quicker. So in that case, you may be able to reduce the time per bed position. As a general rule, it's about 4 to 5 minutes per bed position, but that could change a little bit. If you have a really old scanner, you may need to increase the time. If you have a really new scanner, you may be able to decrease it. So I would follow the recommendations of the manufacturer for that. This image is showing the protocol and the workflow for a fluciclovine study. You will administer it as a bolus. The patient will have their arms down, and then they will move their arms above their head. So with this, it's a pretty good idea to have the patient positioned on the camera for the most part. at least laying down on the camera at the time that you administer the bolus. And then you can have them bring their arms above their head and position them under the camera. You will start the CT acquisition right away. This will take place about a minute and a half or so after the injection because it goes fairly quickly. The CT is done for attenuation correction and anatomic correlation. And then at the end of the CT, you will set them up for the PET acquisition. And it is a static acquisition from mid-thigh to the base of the skull at about 4 to 5 minutes per bed position. So administering the Axumin, like I said, there's about a 3 to 5 minute patient preparation time. So you want to go ahead and get them positioned on the camera, just laying down supine when you give the injection. And then the total image acquisition is about 20 to 30 minutes typically. For the image findings, you always want to compare the fluciclovine uptake to uptake in the background. Smaller lesions, the uptake should be greater than blood pooling. And for larger lesions, the uptake will be greater than or equal to the bone marrow. There are a lot of potential errors with fluciclovine because it is a synthetic amino acid and the normal biodistribution is varied. Of course, if you look liver, pancreas, lung, bone marrow, myocardium, and then it also will distribute into the skeletal muscle. One thing that can affect the image quality, of course, is if the patient exercised within 24 hours before injection. This is an example of local recurrence. Image A is the fused images, B is the CT, C is the PET only, and you can see the arrow pointing to that local recurrence right there. The image on this side is comparing carbon-11 choline to F18 fluciclovine. And as you can see in the yellow arrow there, it's pointing to increased uptake in one small positive lymph node. And this corresponds on the fluciclovine and the choline study. This is another example of F18 fluciclovine showing a focal malignant uptake. And you see it down here where the blue arrow is pointing to, and you see it on the axial images. I do want to point out the normal biodistribution everywhere else. You see that there's uptake in the liver, the pancreas, the skeletal muscle, the bone marrow, and then you see a little focal uptake there that is about the same intensity as the liver, the pancreas. It's a pretty hot uptake area. All right, so now we're going to talk about PSMA imaging. The PSMA agents include F18 PSMA, you have Clarify and Posluma. And then the gallium-68 PSMA agents, you have Illuccix and Locomets. I do want to point out that there are a lot of PSMA agents on the market, and so you may see some disappear or some new ones at the time that you're watching this video, but right at the time of this recording, there are 4 FDA approved ones: Clarify, Posluma, Illuccix, and Locomets. So the first one we'll talk about is plifuflostat, which is called Clarify as a trade name, and it is used for prostate-specific membrane antigen-positive lesions in men with prostate cancer. So if you recall from earlier in this presentation, the PSMA can be overexpressed on the surface of prostate cancer cells, and so that's what these PSMA agents are looking for. So with suspected metastases, patients who are candidates for initial definitive therapy with suspected recurrence based on PSA levels in the blood. And the mode of localization is receptor binding to the cells that express PSMA. This comes from the package insert for Plarify. It is radio labeled F18 with PSMA, and the F18 part is cyclotron produced positron emission. This has a slightly different half-life reported of 109.8 minutes, but it's basically the same thing. It's F18. And we use the 511 keV gamma photons resulting from the annihilation reaction for imaging. Clarify is a diagnostic agent that's indicated for prostate cancer, specifically with these two conditions, like I mentioned earlier, suspected metastases in candidates who are for initial definitive therapy or for suspected recurrence based on serum PSA blood levels. There are no contraindications, but if patients have had androgen deprivation therapy or other therapies targeting the androgen pathway, this may result in changes of uptake of the Plarify. So that's something to, at the very least, document so that the reading physician knows that the patient was receiving that therapy. The recommended dose is 8 to 10 or 9 millicuries of Clarify. Patients should be well hydrated before and after administration. And then imaging takes place about 60 minutes after injection. This one does not, this one also has to be a bolus injection, and patients should void immediately before going on the scanner. And then similarly, this one will begin mid-thigh and proceed up to the skull vertex. So Clarify can be stored at room temperature, but it should be used within 10 hours of being reconstituted. Critical organs are the kidneys, liver, and spleen. And because PSMA is not really prostate specific, the uptake is going to be a little bit widespread. But lesions should be considered suspicious if uptake is greater than the physiologic uptake in that tissue or greater than adjacent background if no physiologic uptake is expected. Tumors that do not express PSMA will not be visualized. So increased uptake in tumors is not specific for prostate cancer also. And that's, like I said, because PSMA is overexpressed in other types of cancer also, and it is something that is normally present in the body in both males and females because despite what the name says, it is not specific to prostate cancer or prostate cells. So this is an example of F18 piflufolastat. First one is more of a normal biodistribution, except for this one lesion down here by the prostate, and you can see it on the fused images below. Same with image B. This uptake up here in the arm is just left over from the injection, but you do see one area of increased uptake down here by the prostate. The rest of that is normal biodistribution. You see kidneys, liver, spleen, bowel, and you see the salivary and parotid glands as well as the lacrimal glands. That's all normal. In C, you see a little bit more extensive metastases into the lymph nodes. You see localized uptake near the prostate, but then also in the lymph nodes of the in the abdomen. And you also see, if you look real closely, you can kind of see some spots in the liver. With D, you see increased uptake, and this is an image in the chest here where you see kind of some uptake. It's probably that one. And then you see a little bit more uptake in the lymph nodes. E, F, and G are extensive metastases, and you'll notice even in F that you see it around the skull, armpits, into the bones. So that is extensive metastases for both of those. And I do want to point out that as you get to F and G, you no longer see the liver as well. And in G, you don't see the kidneys either. That's not because it didn't really uptake there. For one, you will have a lot of stealing of the PSMA dose by all of these hot nodules. So you will have a little bit less uptake in the kidneys and the spleen and the liver. But it's because that uptake is also so bright that it kind of overshadows it. So there's twofold part there for why you don't see the kidneys and the liver as bright or even as you did before. So the next one is the gallium-68 goes to tide. Then this is available as trade name Illuccix or Locomets. With a half-life of 67 minutes, the radionuclide gallium decays by positron emission to stable zinc. And I do want to point out that it has a maximum beta energy of almost 1900 keV and an average beta energy of about 836 keV. So it has a much higher positron energy than F18, remember, and that affects the effective positron range and the spatial resolution of the radionuclide. The mechanism of uptake for the gallium goes to tide agents is very similar. It is still PSMA. This is the same PSMA that is binded to F18. It's just that now it's bound to gallium. So it's still going to go to malignant prostate cancer cells that overexpress PSMA, and it's going to be receptor binding method of localization. Indications are the same. Patients with suspected metastases who are candidates for initial definitive therapy and with suspected recurrence based on elevated serum prostate-specific antigen levels. This one also has an added indication for selection of patients with metastatic prostate cancer for whom lutetium PSMA-directed therapy is indicated. Contraindications are none, but again, that androgen deprivation therapy is something that you want to note for the reading physician because that can alter the distribution. Patients should be well hydrated for this as well. The dose is 3 to 7 millicuries as a bolus, and patients can be imaged between 50 and 100 minutes after administration. Patients should void immediately prior to imaging, and the patient will be scanned. Same thing, start mid-thigh up to the skull vertex. So you go all the way up through the top of the head for that. You don't stop at the base of the skull. And then that one is stored at room temperature and should be used within 4 hours of preparation. Critical organ will be kidneys, bladder, and spleen. And this is an example of gallium-68 gosteotide, which also is sometimes abbreviated as gallium-68 PSMA-11. And so you can see the uptake here. This one has a bladder, and this one does not have bladder activity, but you do see increased activity there. So this highlights one of the reasons why it's really important to have the patient void before imaging. You know, that's difficult with patients sometimes with prostate cancer, but if they have an empty bladder, then that helps to kind of localize some of that foci uptake. F18 has a higher yield and lower energy of emitted positrons compared to other PET isotopes such as gallium. So I want to point this out, and this is important as we talk about other radionuclides in PET that are not F18 also. F18 has a lower average positron energy than things like gallium. And so you can see that F18 is not going to travel as far. When it has a lower average positron energy, that means it also has a lower effective positron range. It's not going to travel as far in tissue before it has that annihilation. So if you look at the picture in the image, or the image in the middle, this is a simulation of the positron tracks form from gallium and F18. So what that is showing is the effective positron range. Like I said, with F18, you have a lower average positron energy, so it's not going to travel as far before it annihilates. Whereas with gallium, it's going to travel pretty far before it annihilates. So that translates to different spatial resolution. So with F18, you have about 1.4 millimeters, and then with gallium, you have about 2.44 millimeter. So you have much better spatial resolution with F18 agents compared to gallium. So indications for any PSMA scans: initial staging of prostate cancer, localization of recurrent or persistent prostate cancer, localization of prostate cancer, which is non-metastatic by conventional imaging, staging before PSMA-directed radioligand therapy. Potential clinical applications also include guidance of prostate biopsy, imaging metastatic cancer, or monitoring of systematic treatment for metastatic prostate cancer. And part of that goes into scanning them after they've had the lutetium therapy to see if there are any PSMA avid sites of metastases that are still active. When you're taking a patient history for patients with a PSMA scan, it is important to get a very detailed history. You want to, of course, include the indications for the imaging study, but you want to know their prostate cancer history. So any primary prostate cancer, if they've had a PSA score or PSA level, what their blood work was. If they had a Gleason score evaluated recently, what was their Gleason score? Prior local intervention or biopsy, any biochemical recurrence, PSA and PSA kinetics, if that's available, current or prior prostate cancer treatments and the dates. This will include the androgen deprivation therapy or any androgen receptor targeted treatments, prior history of the AR targeted treatments, chemotherapy, radium-223 therapy if they have known bone mets, PSMA targeted therapy if they may have had that, prostatectomy, surgeries, biopsies, or radiation therapy. You want to know the dates of that as well. Any relevant symptoms, especially new onset ones: bone pain, frequent urination, nocturia, which is urinating at night, hematuria, which is blood in the urine, dysuria or difficulty urinating, impotence, erectile dysfunction, or painful ejaculation. And previous imaging findings would include previous PSMA ligand PET tracer and the subtype if known, and any relevant comorbidities that would include non-prostate malignancies, allergies, or renal failure. The patient prep: patients can eat and drink normally. Patients should be well hydrated before and after injection. And 20 milligrams of Lasix IV or another diuretic may be given shortly before or after administration of the PSMA ligand to remove activity from the bladder. And this is done optionally. This is not a regular part of the protocol. But that Lasix may help remove activity from the bladder if there's suspected local metastases in that area and the patient has difficulty emptying their bladder. This is a comparison of the PSMA ligands and their dose. So the first one there is F18 pofliflostat, which is also known as Pylarify. Dosage is 8 to 10 millicuries bolus most commonly. prescribed as 9. Uptake time is 60 minutes. The F18 fluflustat, which is very similar, that is trade name Posluma. That dose is 8 millicuries. Uptake time is also 60 minutes. And then the gallium ghostatide imaging agents, the dosage is 3 to 7 millicuries bolus. Uptake time for both of those is 50 to 100 minutes. And those are the ones that are FDA approved at the making of this video. So the protocol is very similar for all of the PSMA imaging agents. Position the patient supine with both arms elevated above the head as tolerated by the patient. The beam hardening artifacts in the abdominal and pelvic regions, as well as artifacts caused by truncation of the measured field of view, can be avoided. And then also the PET-CT data are used for radiation therapy planning. The examination should be performed in the exact radiotherapy position. CT scan should be performed from vertex to mid-thigh per institution parameters. That includes the MAS and KVP settings. CT protocol may be modified according to clinical requirements. For instance, the skull should be included in patients with known metastatic disease. In the case of focal symptoms or disseminated disease, coverage may be extended to include further down the legs if necessary. Diagnostic CT may also be required with contrast enhancement for bone and organ assessments. Additional acquisitions like deep inspiration chest CT may be performed if you're looking for areas in the lungs. If intravenous CT contrast is used, the contrast enhanced CT with portal venous phase is recommended, and it is best to perform that after acquisition of the PET scan. The PET acquisition should start from mid-thigh and extend to the vertex to exploit the reduced PSMA lignin uptake in the urinary system. After the pre-scan voiding, you want to avoid as much activity in the bladder, ureters, and kidneys as you can. Acquisition should also be in 3D mode, and then it is 1 to 4 minutes per bed position, and that is a little bit variable, but again, that's based on the scanner that you're using and the recommendations from the scanner manufacturer. If you're using digital PET, you can tend to go a little bit quicker scan, closer to more like 1 minute. Whereas if you're using an older scanner or you're using a really old dedicated PET, which those hardly exist anymore, but they are out there, then you may want to use more time per bed position. And this is the basic protocol workflow for CT, PET-CT, PSMA ligand imaging. Patient prep is hydration. This is when you would administer Lasix either right before or right after the bolus if you are doing that as an option. And injection is as a bolus for either one of those agents. If it's a gallium, it's 3 to 7. If it's F18, it's 8. And then the patient will continue to hydrate and void. 20 milligrams of Lasix may be administered per protocol. And then the gallium uptake time is 50 to 100 minutes, while the F18 is 60. Patient should void before imaging. We want to have an empty bladder. And then when the patient goes on the scanner, patient is supine with their arms above their head. Scan begins at the thigh and scans superiorly to the skull base at 1 to 4 minutes per bed position in 3D mode. This is an example of the protocol for PSMA lignin PET-CT image acquisition and reconstruction. The CT portion, the field of view will be vertex to mid-thigh. Optional contrast phase should include the portal venous phase because of the liver. And then PET protocol, field of view and acquisition start at mid-thigh and go all the way through the vertex. And then PET reconstruction uses an OSEM or ordered subsets, expected maximization, iterative reconstruction technique with a point spread function or equivalent, and then attenuation correction data will come from the CT. And this is an example of normal biodistribution. So over here on the far left is the gallium agents that are FDA approved. And then over here in the middle, the F18DC, FPYL is the Plarify that we see. And so these are the two that are FDA approved. And they are both kidney dominant excretion. And you'll see that they're essentially look very similar. I do want to point out, because of the effective positron range and positron energy, the spatial resolution will be better with the F18 agents. Now we're going to shift gears a little bit and talk about some of the other prostate cancer imaging agents, particularly the carbon-11 agents. Carbon-11 has a half-life of 20.4 minutes. It is produced in a cyclotron, and it decays to boron-11. Carbon-11 is widely used in research and easily tags to compounds and lignins. Carbon-11 choline and carbon-11 acetate are the two FDA-approved agents. The chemical form for carbon-11 is choline. The mode of localization is that it is a water-soluble nutrient that is transported into cells as a precursor for biosynthesis and phospholipids, which are cell membrane elements. Choline represents fatty acid metabolism of cell membrane production, and it is more metabolically active in prostate cancer cells or prostate cancer cells that have metastasized. Indications for carbon-11 choline are increased PSA levels after treatment, or recurrent prostate cancer where suspicion where bone scan, CT, or MRI were not conclusive. This one is not typically used as an adjunct to fluciclovine, FDG, or PSMA. Maybe FDG, but not PSMA or fluciclovine. It's usually used in place of those. And I do want to preface this whole choline agents by saying that if you recall, the half-life is only 20.4 minutes. Recall that it is very difficult to transport a radionuclide with such a short half-life like that, or make it commercially available. So choline 11 or carbon-11 choline and carbon-11 acetate are predominantly just used by research facilities that have an in-house cyclotron or cyclotron really close by. So choline is an essential nutrient that's was formerly classified as a B vitamin. It's similar to an amino acid in structure and function. It is responsible for cell structure, fat transport, cell messaging, DNA synthesis, and the nervous system, the heartbeat, memory, and muscle movement. So it is indicated for patients with prostate cancer recurrence and non-informative bone scintigraphy, CT, or MRI. The typical dose is 10 to 20 millicuries, and of course there's no pediatric dose for that. This is an example of the normal biodistribution and uptake for carbon-11. You do see activity here in the arm that is from the injection. You'll see uptake in the liver. It's normal to also see kidneys and a little bit of bowel. Carbon-11 decays by positron, and that 20-minute half-life is what limits the distance a dose can be sent. In image A and B are the same patient, image C and D are the same patient. So you'll notice that there's a little bit of uptake down here. And then with this one, there's a slightest little bit of uptake down there. Imaging errors have been reported with carbon-11 choline. PET and PET-CT imaging. A negative image does not rule out the presence of recurrent prostate cancer, and a positive image does not confirm the presence of recurrent cancer. So the uptake is not specific for prostate cancer and may occur with other types of cancer, such as lung carcinoma or some brain tumors. Clinical correlation has to be done, including histopathological evaluation of suspected recurrent sites, and it is essential, to the proper use of PET imaging information. So it's very non-conformatory. And then blood PSA levels greater than 2 nanograms per milliliter have been associated with poor performance of choline. So they'll have higher numbers of false positive and false negative results. And then tissue inflammation as well as prostatic hyperplasia have been associated with false positives as well. It will uptake in areas where there is inflammation. This is an example of a 55-year-old patient with increasing PSA levels. PSA levels were 1.43, 27 months after radical prostatectomy, and the Gleason score was an 8. So these images show coronal, axial, and sagittal fused image projections of the PET-CT scans and the focal 11 carbon 11 choline uptake in the right, where the arrow is pointing, and the left thin arrow in the iliac region revealed lymph node involvement that was not observed on the FDG PET study. And this is an example of a 77-year-old who had post-radical radiation therapy, and PSA is now 6, and the blue arrow is pointing to lymph node recurrence, and you can see on the coronal views that there's some minor lymph node recurrence. So the next one is carbon 11 acetate, and this is basically a salt. The energy expenditure, lipid metabolism, and innate immune responses are things that acetate are involved in. The mode of localization for this one is that it is quickly metabolized into the acetyl-CoA in human cells. In this form, it can either enter into a tricarboxylic acid cycle or producing energy, as happens in the myocardium, or it can participate in cell membrane lipid synthesis as it happens in tumor cells. So carbon 11 acetate actually has a wide variety of uses because of the short half-life and because it is restricted to being very close proximity to a cyclotron. It is not commonly used for a lot of these things, and it is not readily available, but carbon 11 acetate is used for myocardial blood flow reserve calculations, renal cell carcinoma, hepatocellular carcinoma, multiple myeloma, gliomas, and rare tumors. This is an example of a carbon 11 acetate study. This is a normal scan. You see that there's a lot of uptake in the pancreas. You also see liver, spleen, some bowel uptake, a lot of non-specific uptake, and then you see a little bit of uptake in the glands in the face. The last thing I want to talk about is PET-MR. PET-MR scans are better than PET-CT for local tumor staging and detecting local recurrence. They also have a slightly higher detection rate than PET-CT scans in lymph node recurrence. So PET-MRI is suitable for local and regional disease, either primary staging or restaging, and has been very valuable in patients with suspected prostate cancer recurrence. PET-CT is valuable for managing distant bony or visceral metastases. PET-MR, although it is sometimes more difficult for those patients to stay still for longer periods of time, and not everyone can have an MRI, it also reduces the radiation dose to patients who are getting a lot of radiology tests. And that concludes the lecture on prostate cancer imaging. Thank you for watching. Hope you enjoyed.